Good afternoon. Good afternoon, everyone that was able to join us. We're very happy to host this event today. My name is Dr. Elena Rios, and I'm President and CEO of the National Hispanic Medical Association. And I want to thank Amgen for sponsoring today's program. NHMA is a nonprofit association representing the interests of 50,000 Hispanic licensed physicians in the United States. And our mission is to empower Hispanic physicians and others that serve Hispanic patients to lead efforts to improve the health of Hispanic and other underserved populations in partnership with all of our residents and medical students, as well as our medical societies and public and private partners. We are excited to host this series of webinars about improving access to biomarker testing in order to improve cancer care as Hispanic communities continue to face disparities in cancer survival. We hope by sharing this issue, we will highlight the need to increase access and use of biomarker testing among physicians. Our first speaker will be Dr. Estelamari Rodriguez. Dr. Rodriguez is an Associate Director of Community Outreach and co-lead of the Thoracic Site Disease Group of the NCI designated Sylvester Comprehensive Cancer Center at the University of Miami Miller School of Medicine. She's board certified in medical oncology and hematology and has a special interest in the early detection of lung cancer and developing programs to eradicate healthcare disparities. Following Dr. Rodriguez will be Devon Adams, a nurse and senior analyst for policy and legislative support at the American Cancer Society Cancer Action Network, also known as ACS-CAN. He will then join a roundtable discussion with Dr. Rodriguez. Everyone watching us live this afternoon, we would please ask you to ask questions in the Q&A box. We will do our best to incorporate the questions in our discussion at the end. I also have some housekeeping messages here. We'd like all your microphones to be muted. Please feel free to use the raised hand feature to be unmuted to ask a question or type your question into the Q&A box. The recording will be housed on the nhmamd.org website and our National Hispanic Medical Association YouTube channel. The recording and the slides will be available a week after the event. We'll send them to everyone that registered today. So let's get started. We have an agenda and learning objectives. So we will have our overview of biomarker testing presentation from Dr. Rodriguez, followed by a legislative discussion from Mr. Adams. And then we'll have our roundtable discussion, and then lastly, Q&A from the audience. So please, again, put your questions in as you hear the speakers. The learning objectives today are to educate health advocates about biomarker testing among Hispanics with cancer, and to discuss policies that are potential New York State solutions to barriers of biomarker testing. So Dr. Rodriguez, would you like to go ahead and get started?
Great, thank you so much for the invitation. I'm delighted to be here with you this morning to discuss a really important topic in the management of patients with cancer. So it is the importance of biomarker testing, which is something that when many of us went to medical school and trained was not something that we were concentrating on, but it's very much at the center of the diagnostic workup. Next slide. So cancer mortality among Hispanics, although if you look at the rates of cancer comparing non-Hispanic whites and Hispanics, the rates of Hispanics are lower. However, the leading cause of cancer mortality for Hispanics remains cancer, where non-Hispanic whites as the second leading cause. So cancer does take a significant burden. For males, lung cancer is the #1 cause of cancer death in the United States, and for women is the second leading cause. But it's a very prevalent cancer that I treat patients with, and we have to kind of educate ourselves about how the management has changed and how biomarker testing has really transformed the way we treat patients. Next slide. Now, racial and ethnic disparities is a hot topic, and we've been seeing that for a long time. But when we look specifically at lung cancer, we know that the Latinos with lung cancer are 16% less likely to be diagnosed early. And that really speaks to access and health insurance access, because to be diagnosed with lung cancer, you have to go through several hurdles. You have to have a physician that recognizes your symptoms and has a high index of suspicion that this could be a lung cancer, so a cough. I can tell you how many stories we have of patients that had lung cancer during COVID that was misdiagnosed or delayed in diagnosis because they either were not being seen by doctors or their symptoms were not addressed. So we know that Hispanics have a challenge in terms of early diagnosis, but when they actually get to the doctors and have insurance, they're as equal likely to have a surgical treatment. So the curative treatment options for Hispanic patients are there once they get in the system. The other thing that is of note is that Hispanics in general, 26% are more likely not to receive any treatment. And this is something that I've seen a lot in my practice over many years, that sometimes the very elderly Hispanic patients are not really brought in to cancer centers for aggressive care, and clinical trials are not considered. So there is something to be looked at in terms of like Hispanic patients that have lung cancer and never had treatment. That is something that we need to address. Is it an access issue? Is it a preference or lack of education? And in general, lung cancer patients, Hispanics, once they have lung cancer, they're 16% less likely to survive at 5 years. Next slide. So what is biomarker testing and why are we talking about it this morning? Next slide. So biomarker testing is really any molecule that you can measure in your blood, in the tumor tissue, which is really the gold standard. In other bodily fluids, we do biomarker testing in the urine, in the spinal fluid, and this information can help inform treatment decisions. And before, it was more of a research discovery tool, and now really it's an essential tool to select the right treatment for patients from the get-go. Comprehensive biomarker testing, which means looking at all the mutations that are present that we know, and some of the ones that we have yet to find treatments for, is critical so that your healthcare team can identify your appropriate treatment option. And the timing of this is really critical. So for lung cancer patients, lung cancer is a very aggressive disease. As I mentioned, it takes some time to get the insurance, to get the biopsy, and to get to a doctor. So once you get to a doctor, making decisions fast about treatment and the right treatment is critical. The current guidelines from the NCCN, pathology guidelines, and ASCO recommend that broad molecular testing at the time of diagnosis is offered to all patients with advanced and recurrent lung cancer. And I think what really has changed and transformed the treatment of lung cancer patients is that the genomics, the understanding of the genes, the mutations that drive the tumor, and this biomarker testing has revolutionized the discovery and most of the investigation of new targets. So we have treatments today for patients that 10 years ago were not even, we didn't even recognize. And these patients today are living a good quality of life and longer life because those treatments are available. Even during COVID, we have new drugs, which I'll show you, that were approved based on this research that were not available before. Next slide. So in the past, we thought that all the lung cancers, and we have, this is equal for breast cancer and other cancers. In the past, we only looked under the microscope, and our definitions were very raw, like adenocarcinoma, squamous cell carcinoma, small cell carcinoma, non-small cell carcinoma. But now we know that there are many mutations that drive tumors, and patients need to be treated for those underlying driver mutations. So 35% of patients today that have advanced non-small cell lung cancer, that is adenocarcinoma, have a driver mutation that we have an FDA-approved agent. So if we don't do that testing and we don't identify those patients, we are taking away options, and we are really decreasing the survival of those patients that have not been treated appropriately with all the agents that are in their slide. These are all drugs that are approved. And many of them, as you can see on the left, EGFR, which is one of the more common mutations in non-small cell lung cancer, has gone through several lines of generations of drugs, and each drug gets better with potentially less toxicity and more efficacy. Next slide. So this is just a real slide. I didn't take this from the internet. This is a patient that was treated at one of our prior practices that I worked in, and there's not a typo. In 5 days, this patient had patient was in the ICU on oxygen support, And at that point, it was 2002, that was the beginning of understanding EGFR mutations in lung cancer. This is an Asian woman who was a never smoker, and she ended up having a mutation called EGFR. And at the time, we had a drug called erlotinib and gefitinib. Those two drugs were the first ones in the market, and the patient was enrolled in an early trial, had access to this drug, and truly came off oxygen and was able to go home, which is really a message that if you ask oncologists that treat lung cancer, they have seen the story with new mutations that have been discovered, that patients were about to give up, and there are options for those patients. Next slide. So I kind of hinted at this, how biomarker testing has driven the discovery and drug approvals in lung cancer. And this is really a timeline of really what was going on in lung cancer. We really had nothing. We had chemotherapy, and the survival was not better than 8 to 12 months in patients that presented with advanced lung cancer. In the last 20 years, really with the understanding of targeted therapies and this biomarker testing driven treatment, we are able to have new pills, which are targeted therapies, new immunotherapies. And you can see that since May of 2020, we have several drugs that we never had before. And I want to highlight at the end here in May 2021, we approved drugs for KRAS G12C, which is a very common mutation, one of the most common mutations in lung cancer. Those patients previously didn't have an option, and very rare EGFR mutations that we're learning to understand, like EGFR exon 20. So really a lot of promise. And what we have seen is that 60% of the drugs that have been approved in the last 10 years have been driven by biomarker testing. Next slide. So barriers to access for biomarker testing, and really why we're discussing that today. Next slide. So we know that we have ways to find these mutations so that we can select the right treatment for each patient. So how do we get each patient tested? So first we have to get patients to a doctor that makes a diagnosis. And then we also have to have the doctors recognize that this is an important part of the diagnostic workup. So when we have looked at the recent data, and these are data from retrospective series of 28,000 patients that were newly diagnosed with lung cancer, we see that the adherence to testing in the first 90 days from that diagnosis is still in the range of 50%, so that half the patients are getting started on chemotherapy without really having the full range of information that will help you select targeted therapy. And for patients that are found to have mutations, if they didn't have that testing up front, there's a decreased mortality risk by 11%. So that you're really, really impacting their survival by not picking the right treatment. So I think the message here from this morning is that regardless of the patient characteristics, such as age, race, smoking status, because initially many of these targeted therapies mutations were seen in never smokers, but we see it all the time in patients who have a smoking history. Biomarker testing should be conducted at the same time that you're doing a biopsy in all eligible patients with lung cancer. Next slide. And here's another abstract that got a lot of attention to us oncology conferences ago, and it was also a real world cohort of 14,000 patients in the Flatiron database treated from 2017 to 2020, so very recently. And they looked at the rate of testing by race, and they found that Black patients were less likely to get NGS. And what was really important is that if you really take away that information, you're really taking away options. So participation in clinical trials was way lower in patients who didn't have biomarker testing. Next slide. Now we'll show you the numbers in the next slide. So when we look at all ever tested, it was only 39% of Blacks versus 50% of whites. So we're still not doing well in whites, but we're doing worse in minorities. And then we can see that for all patients with non-squamous cell carcinoma, and that impacts their treatment options, the likelihood of them going into a clinical trial. Next slide. Also, that moves slowly. So I think about this a lot, biomarkers to biomarker testing of the patients, because we see patients as a second opinion that have already waited to get to us for several months. And even when they get to us, they don't have this testing. And now we have to do the test and wait for the results, so that it adds a delay that is unnecessary. And how we can really address this. So there are many reasons for this lack of testing in our population. One thing that people don't talk about is this implicit bias. I feel like at the beginning of this story of biomarker testing and mutations, the description of these patients were patients that were never smoker, and many of the patients who are out in social media that are the face of many of these mutations are non-Hispanic patients. So people don't really meet a patient and think, oh, this is a patient that I need to do testing for. So we want to take race out of this ordering. I think biomarker testing should be offered to all patients. But patients need to have health insurance coverage to be able to pay for the test, to pay for the biopsy so that the biopsy can be sent for the test. So physicians need to be aware that when they meet a patient from the get-go, when they get a biopsy for a suspicion of lung cancer, we have to have enough tissue to be able to do this test. We also have to have access to testing. We know that some of these testing companies, some cancer centers are more used to doing it. They can do it in-house, but there are several companies that you can send the tissue. So we have to make sure that this is available to rural and urban communities. Tissue insufficiency is a big issue because we have patients that come to us and the biopsy that was done was a very minimal biopsy to make a diagnosis, but not enough to do biomarker testing. We do have now liquid biopsies, which are based in blood testing that can help us, but still having tumor biopsy will be critical. And then health literacy and awareness. So I think the best way to overcome this barrier is for patients to know that this is part of their required testing. So that when a patient comes to a doctor with a new diagnosis or a family member comes and has a family member with a new diagnosis of lung cancer, they have to ask their oncologist, so what type of lung cancer mutation do I have? Now, not every patient has a mutation that we can treat, but we at least should look. And I think patients demanding that from the get-go would really move things farther and make sure that patients get the adequate treatment. And I think what I wanted to show you in the last slides is that when you don't have this information, you limit options for patients. So we have patients that could be in clinical trials, that could have been in clinical trials, and we never were able to offer them that option because we never knew this information. Also, I believe in our community, fatalism and belief systems play a role. So I have had conversations with families where a patient comes in, we have a diagnosis, we know it's a difficult diagnosis, and I will need to have more information to pick the right treatment, but the decision from the family and the patient are like, I can't change this, nothing good can happen, I don't want to do more. And I feel that, one of the messages and one thing that has really we've seen in lung cancer is that lung cancer is a treatable, advanced lung cancer today is treatable. We have more patients that are surviving 2 and 5 years. So really offering options to patients and having a conversation with patients about the importance of repeat biopsies and biomarker testing is critical because many of these options are options that can be tolerated very well. So many of these are pills that my oldest patient that I have treated today is 88. So these are drugs that patients can tolerate as they get older and we can manage. Thank you so much. Next slide.
Thank you, Dr. Rodriguez. I think it's very interesting. I look forward to the discussion. Let me now turn it over to Devon Adams from the American Cancer Society Cancer Action Network to tell us more about, what kinds of policies already are happening and what can we do to support and advocate for better policies to look at some of the barriers that Dr. Rodriguez just mentioned about testing and biomarkers.
Sure, and thank you so much. Really excited to be here today to kind of talk through this with everyone. For those unfamiliar, ACS-CAN is the policy affiliate of the American Cancer Society, and we advocate for evidence-based policies to support cancer prevention, detection, and access to care. We have staff and volunteers who work in every state, territory, on local, state, and federal policy. And we really see biomarker testing and, importantly, access to biomarker testing. It's a really big priority to us because it's really about connecting the right patient to the right treatment at the right time. Next slide. So Dr. Rodriguez did a wonderful job highlighting the examples of the benefits of biomarker testing and why biomarker testing can lead to targeted therapies. It can improve outcomes for patients. And I think that slide you showed was really striking, showing the remarkable success of treatment with biomarker-informed therapies. But we know that all patients are currently not benefiting from biomarker-informed therapy or biomarker testing. In 2020, we released a policy report to explore some of the barriers to cancer biomarker testing, and we really identified several. As you can see with this illustration, there are several steps, and Dr. Rodriguez talked about this as well, before a patient can benefit from those biomarker-informed treatments and therapies. And barriers can really arise at any point along the way, along those steps. First, there needs to be reliable and valid tests available in the market. Second, patients will often need a biopsy that attains enough tissue in order to do the biomarker testing. Third, providers need to be aware of what tests to utilize and when, and as well as how to utilize these results in caring for their patients. Fourth, insurance coverage is an essential component for patient access. And finally, healthcare facilities need to really be equipped with the appropriate infrastructure in order to do biomarker testing. So one of the biggest opportunities for improving access that we've identified is really an opportunity to address the insurance coverage of needed testing, particularly as it relates to state-regulated health plans and Medicaid. Insurance coverage is really a barrier, a really important, significant barrier to increasing access to biomarker testing. For example, one recent study found that 32% of New Yorkers in fully insured commercial plans are in plans that are considered more restrictive. That's more restrictive than the National Comprehensive Cancer Network or NCCN guidelines for that comprehensive biomarker testing for lung cancer, melanoma, and prostate cancer. In other words, there needs to be some work done to expand coverage for patients. And we at ACSCAN conducted a survey last year of 315 oncology providers, really examining the barriers that providers are facing in performing recommended cancer biomarker testing. And we really saw that this concern about cost and coverage was at the forefront of their concerns, with two-thirds of respondents reporting that patient insurance coverage for desired biomarker tests is a significant or moderate barrier. And these insurance obstacles were the most frequently mentioned concern in our open-ended questions that we had. So we really know and heard directly from providers that insurance coverage is a barrier. And we also, really important in that research that we conducted, we found that 91% of providers who were doing biomarker testing consulted clinical guidelines such as NCCN guidelines. Next slide. So to address this insurance issue that we're having with as far as coverage of biomarker testing, ACSCAN has engaged on a state-by-state campaign with this disease-agnostic model legislation that we've created to require more insurance plans, including Medicaid, to cover biomarker testing for the purposes of diagnosis, treatment, management, or monitoring of an enrollee's disease or condition when the test is supported by medical or scientific evidence. And I'll point out that the model legislation is intentionally disease agnostic because while we know cancer is kind of at the forefront of biomarker testing and connecting to targeted treatments, there really are some developments going on in other clinical areas such as rheumatology or cardiology. This legislation was developed in collaboration with many partners, including patient groups and provider associations. And it's really important too in our legislation that we really connected it back to that medical or scientific evidence indicating that testing is needed. So for example, clinical guidelines like NCCN. Next slide. So this is just a snapshot of our legislation and what's happening in the states. And happy to report we've had some recent successes with our legislation passing. Illinois was the first state in the nation to pass our model bill, followed by Louisiana, Arizona, and as of 2 weeks ago, Rhode Island. Currently, we have active bills in California and Ohio. And the bill was also introduced in Minnesota, Washington State, and in New York. In New York, it was introduced in January, but it didn't move this session, but will be picked up when the legislature returns in January 2023. And our bill champions were Senator Prashad and Assemblywoman Hunter. And we anticipate additional states coming in 2023. So what's really been key to our efforts in the states where this legislation has passed is really education of lawmakers to help them understand the problem that we're facing and the opportunity for biomarker testing to really lead to improved patient outcomes. It's also important that we have the involvement of patients and healthcare providers who share their stories. You know, the patients and the providers are on the ground and they're seeing what's happening. So sharing their successes to help really get lawmakers excited about what's going on and the developments in biomarker testing and targeted therapy. And a third key factor is just collaboration across patient and provider groups to highlight the broad support for this effort and needed action. Next slide. ACS Canada has several resources related to our work engaging in biomarker testing. So if you want to, feel free to check out those resources at fightcancer.org/biomarkers. And excited to hear or welcome any of your questions. I'm excited to participate in the discussion. Thank you.
Okay, thank you. I want to remind the audience to please put any questions in the Q&A chart box. Right now, we're going to have a small roundtable discussion. We have some questions that we wanted to ask to clarify some of the items that you've all discussed. Dr. Rodriguez, could you talk about biomarker testing and how you've seen it improve cancer care in your practice? You did show us a remarkable X-ray of a patient, but has there been more uptake of biomarker testing or more awareness from patients and from your colleagues at the cancer center where you work?
Yeah, I mean, I think that where the patients that come to us, to our cancer center, a lot of them are very educated. They go on the websites, they go on the internet, but there's still a lot of room for more awareness for testing. I think what I've seen is that some of these drugs, for example, we have one of these drugs that I mentioned, the EGFR, now we can use it after surgery. So there's opportunities for these drugs, for this information to inform the whole care of the patient and the whole journey of the patient. I think we need to get more faces of Hispanic patients that are on these treatments that are doing well. We try to do that at the University of Miami when patients are courageous enough to tell their story, because I think that people need to see the stories. People need to see the stories that we have young patients. A lot of these patients with actionable mutations are very young. So we have young patients, young mothers, young men who get diagnosed with advanced lung cancer, and everything looked gloom until we found out that they had an option that was a targeted option, that there's a lot of research, a lot of treatments that work much better than chemotherapy can for these patients. So I think that there needs to be awareness. We need to kind of increase advocacy from the patient perspective, that we see more patients like ours, Hispanics, kind of telling their story, so that the next time a patient goes into a doctor's office, they demand that information.
Sorry. Well, thank you very much. Devon, let's ask a question about biomarker testing and the importance of awareness when you talk about the American Cancer Society advocacy, and how can you increase awareness? What are you doing to increase awareness among our patients and as well as the providers in our communities?
So that's a really, really important question. And I think what's important to note about, excuse me, our state campaign is before we introduced, our legislation, we went in there to, to help educate, to help lawmakers understand what is biomarker testing and how does it relate to treatment and what are really the outcomes from biomarker testing. So I think what's really been successful to our efforts is first, before, just really laying the groundwork out of this is biomarker testing, this is what's happening when patients, get the testing and they're able to have these targeted therapies. And the stories that we get from patients and providers is they're really powerful stories, and they really go far in getting people on board with increasing access. I know we have an effort underway now where we're collecting these patient stories and stories and videos, just really highlighting the patient's journey from getting the testing to getting the treatment to showing what their outcomes ultimately are. And that really goes a long way in increasing awareness, showing the remarkable success you can have with some of these treatments, especially as Dr. Rodriguez mentioned, lung cancer, a couple of years ago or decades ago, it's a death sentence. People are really afraid. It's a scary diagnosis. But now today we have people who are alive and thriving because of these treatments that were only discovered because they had the biomarker testing to get the specific treatment for their specific cancer, and now they're living longer and having better outcomes.
So, Dr. Rodriguez, it seems very powerful, your slides. And also with the American Cancer Society behind advocacy, it seems that this is something that the National Hispanic Medical Association can certainly increase and awareness that among our networks, not only with these webinars that we're doing, but at our conference. I'd like to ask you to think about being a speaker at our conference.
Yeah, yes, sir.
But let me ask you to talk about, and this is something that's a little sensitive, we can't blame everybody in healthcare, but there certainly is a role here for insurance to step up. How would you discuss, what can you discuss from your own experience? How difficult is it to get insurance companies to actually cover biomarker testing right now, since it's so new?
Yeah, I think that, that is a critical point. And so not having a standardized approval for broad testing only adds delays to patients. So, if a patient that we meet, now we have to get something else, another thing approved, which is another test, then that adds another week to something that is very critical for the patient. Also, we know that patients that have Medicaid, which many of our Hispanic patients can have Medicaid coverage of some of this testing is not throughout every state. And it's very difficult. We sometimes try to get free testing for many of our patients, but we have to think long and hard about how some patients with resources can get the high technology, high level care, and other patients do not. So this is something that we all need to fight for to make it uniform. So I think the insurance company can step up not only by kind of delaying by making it cover from the beginning, so there's no delays in what's already a very critical time for the patient. Also, many of our patients that have actionable mutations are very young, and the financial toxicity of having to cover the test plus the treatment becomes something unsurmountable. So, I have a patient who is a graphic designer, and he had to quit work and go into disability because between the cost of the targeted treatment and the cost of the testing, it really became very difficult. So really making it accessible for patients at a time they need it and not adding to the cost. Some companies we have seen, they will cover like the cheapest test available, which is one mutation, when in reality, when you meet a patient and this is their life, you want to understand all the mutations that you could potentially treat. So this is why we advocate for more broad testing, so that we only have a certain amount of tissue on patients when we meet them. And if we do one test and then wait for that result and then send another test that is broader, you eventually run out of tissue and you are delaying care unnecessarily. So getting all the information up front just opens space. We have at the Sylvester Cancer Center, many centers have this tumor agnostic, which means that you can get treatments based on the biopsy, not the cancer. So if we know that a patient, for example, with bladder cancer has a mutation, that there's a drug in breast cancer that can be used, knowing that information about the mutations of that cancer opens options for this, what they call basket trials, where you can put patients based on the mutation information and not the diagnosis of the cancer. So I think for many reasons, we need to make sure that this is covered universally so that we can make treatment decisions quickly for the patient and we don't add to the burden, the big burden that is already for patients with a cancer diagnosis.
Thank you for that. This is really amazing. Devon, you mentioned how your role really is to advocate for these policies and how many states have already approved the policies to decrease the barriers to testing. In your policies that have been successful, how have they related to the insurance coverage? Are they insurance coverage in Medicaid as well as commercial insurance and Medicare?
So yeah, and just to highlight some points to your question and what Dr. Rodriguez mentioned, the evidence does show that patients who do have Medicaid are less likely to get those guideline indicated biomarker tests. So we are clearly, seeing a disparity there. And also to Dr. Rodriguez's point about that really comprehensive testing, making sure we have all the information up front. And one of the barriers that we're seeing is that coverage for those, comprehensive tests that look for more than one, single gene that can be actionable. We're really having a barrier with coverage for those types of tests, specifically. And I've been involved in some research that shows that, a lot of these plans are really more restrictive than what's recommended in NCCN guidelines. And just from some of our own research, providers rely on those guidelines when they frequently consult those guidelines when making their decisions. And you have a patient who maybe has, an insurance policy that's more restrictive than what, the guideline is helping the physician understand and helping, guide their treatment. So there's really that disconnect there. So we really wanted to make sure that with, those state regulated health plans and Medicaid to ensure that when the science, when the guidelines are telling us that this testing is best for the patient, it should be covered, just simply.
So let me ask you again, did the states that did approve policies for biomarker testing include Medicaid?
Yes, that is.
That's a definite victory. Great.
That is
okay, how about
our model legislation? And what's going to be interesting to see, as I mentioned, plans being more restrictive than guidelines. As a case study, interesting case study, Illinois was one of the states where they had a high number of, their population who were considered to be in these restrictive plans. So it's going to be interesting to see, over time, that number decrease because of this, legislation. It's kind of a way it can kind of be measured to see, the success that we're going to have with this legislation.
Yeah, no, that's great. And I'm assuming you're working with Congress too. How's that happen? Is that moving forward?
So we intentionally,
Medicare, for example,
with this campaign engage on a state-by-state campaign rather than a federal campaign. What we're seeing as far as coverage, Medicare has much better coverage for these types of tests than those state-regulated plans and Medicaid. It's really where we're going to be able to move the needle the furthest is in those types of plans. Okay.
Well, that's good. Let me ask you one more question, Dr. Rodriguez, and then I'm going to go to some of the questions that are in our Q&A box. In terms of providers that are not cancer doctors, when should they refer to the oncologist for lung cancer? How soon? And you mentioned that the biomarker testing should be done at the time of tissue biopsy to maximize the cure rates, right? Is there a timeline change now that we have more opportunity for better drugs and better therapy for lung cancer?
Yeah, so, I think that there's a big opportunity to move testing up front, even from the time patients come in with symptoms. So the University of Pennsylvania recently did a study where they activated biomarker testing from the moment the patient was diagnosed for a biopsy, and they showed an improvement in outcomes because patients were getting that information before they actually saw an oncologist. So I think the message here is that in the past, in many hospitals, and actually this is something that we didn't discuss, at some point Medicare will require that this testing will be ordered after, I think it was after a certain amount of days after the patient left the hospital. So that in itself, the hospitals were not allowing doctors to order the test when they were diagnosing the patient. They were waiting for the patient to be seen by an oncologist. So all these rules that are done for billing purposes sometimes really have meaningful an impact in the treatment of the patient. Yes. So this opportunity to test early and have our pulmonologists be aware of testing in the community is critical, because it doesn't have to be an oncologist who orders this test.
Great. No, that's a good message. We all need to educate our physicians, especially with the National Hispanic Medical Association wanting to educate and improve health. This is a great example of how we can do that. So let me turn to a few questions here. Let's say one question from Michael says, what percentage of patients do you think don't get biomarker tested for purely cost reasons? And you both have mentioned cost being, a big barrier.
Yeah.
Rodriguez, you have any comment?
Yeah, I mean, we have the data, the real world data, that is about half the patients don't get tested before their first treatment. And I will say about, half of those may have issues with cost, that either there's an assumption that the insurance is so difficult, let's just get started on treatment and look at this information when we can, so that the physician is kind of trying to make decisions fast and starting chemotherapy without having this information because of the burden of prior authorizations and so forth. So I think there's a significant amount of patients. And I think what we don't measure sometimes is the patients that get stuck with a big bill because the test was done and there's no coverage for the test. And many of the companies that do testing, one thing I wanted to mention is that the evolution of testing over time is really remarkable, that we can do some of these analysis in the blood, that the cost of the drug or the testing is cheaper. There's more competition in the market. And it used to take months to do genetic testing, and now it can take us like 7 days to get all this information. So I think that that has really make it better, but it is a significant burden not to have it covered by insurance because it adds to the financial toxicity to the patient.
Yeah. And not only the patient, but the family. Oh my goodness.
Yeah.
So let me ask Devon a question, and it's a little bit of a different type of question, but it is a very important policy given the days that we are in, called climate change and climate justice that's needed. Do you think that there should be any consideration of patients that are exposed to waste, to hazardous waste, to other climate, I'm going to say climate, toxins within our air, et cetera, that could lend to cancers and other environmental problems that happen with lungs in terms of biomarkers?
So, if we look at the numbers and, some of the causes of lung cancer and just kind of seeing what's driving, I would definitely think that and definitely say that there is that environmental component of, what's in the air driving. We all know that, smoking is a contributor, but also, things such as radon are a contributor to lung cancers as well. I can't speak too much on as far as what, the differences in the biomarkers that may, show up, show up related to your exposure to different types of toxins. But I would definitely think, for sure that, what's in our air, our water, all of those are contributing factors. And maybe Dr. Rodriguez can speak to kind of.
Yeah, I mean, I think, we don't understand, we don't really have a specific test that tells you this patient is at risk based on the environmental, but we do know that many of these actionable mutations are really impacting never smokers. It's actually the fastest growing group of patients diagnosed with lung cancer are these young women and young people with no smoking history. So we really have to, that really begs the question of why is in the environment that is triggering this epidemiologic change. It's actually very big. If you look at in the worldwide, in Asia, that's also a very big epidemic although pollution there could be proven probably very differently, but there's still something in the environment. And I think we definitely need to do more research in our communities, especially occupational exposure. We have patients that work in factories. They get exposed to different toxins that not the average population is exposed to. And we are seeing younger people with lung cancer who don't smoke. So there has to be something in the environment to explain that.
Yeah. Well, that's important to talk about never smokers. We always talk about the smokers. But anyway, another question here for Dr. Rodriguez is, could you talk about what is the treatment difference, or is there a big treatment difference between, well, obviously there will be, but what is the normal routine for non-biomarker testing patients, those patients that didn't get biomarker testing for lung cancer versus those that did? You mentioned length of life, that they can live longer with the targeted treatment.
Yeah. So I think one of the biggest differences between targeted treatment that we've seen and standard chemotherapies is that targeted therapies, for the most part, they're small molecules, they're pills, and these small molecules penetrate into the brain. So one of the reasons why many patients that are treated with the appropriate targeted therapy live longer is that they have better control of their disease in the brain, and they have these drugs. One thing I haven't really highlighted is that these drugs are targeted, meaning that they go after cells that have a mutation and they leave most of the other cells in the body that are normal. They don't leave them untouched, which is very different than chemotherapy. When we use chemotherapy, which is cytotoxic, it kills every cell going after that cell with a mutation that is cancer. And we see that sometimes the toxicity of chemotherapy is greater, and that adds to the difficulties with survival and tolerance of treatment and patients stopping treatment early. We also seen that in immunotherapy, which is something that has really also changed the management of lung cancer. If you give patients immunotherapy, but they actually ended up needing one of these targeted options, you can cause harm, because if you started chemoimmunotherapy because you didn't need a lot of testing and did that, and then you found out they had an EGFR mutation, the treatment that you used for the EGFR mutation may cause added toxicity to the lung after receiving immunotherapy. So there's a lot of nuances to the treatment, how the treatments are started. And really the message here is that these patients will do better with a biomarker driven testing up front. They will live longer and they will have less toxicity.
No, I think that's wonderful. Just a big comment from someone, from Nando Diaz, that says, great presentations, but how do we begin to educate the Hispanic population? What do you think should be our first steps with so many needs in the population, from health literacy, just understanding that what is cancer, what is lung problems, educational attainment, language problems, in terms of translators, and just health communications in general. And then, of course, we have a lot of farm workers and people living in rural communities or along the border or in Puerto Rico, where there's less access everywhere. So
I'm in Puerto Rico right now.
What would you tell us as the National Hispanic Medical Association, very interested in advocating for our communities, and working with you all in policy world and advocacy, what do you think we should start doing about biomarker testing? How can we elevate it?
I think that, what you all mentioned, it's so many levels, but I think community partnerships are key, because I think in rural communities where we don't have big cancer centers that are present, you really need to rely in the community partnerships, like community organizations that could really bring the message about screening for lung cancer, recognizing symptoms of lung cancer. And I think during COVID, we really saw this really dramatically, patients that were not seeking care with heart attacks and they were not seeking care with lung cancer, and time is of essence. So I think the message being, how do we increase access to patients that don't have insurance or help them get insurance? I think community partnerships are key. I think another thing that I would like to see is more patients like me out there on social media, on Facebook. There's a lot of this actionable driver lung cancers actually have groups in social media that are organized by patient advocates. And we need to have representation from our patients so that they have their message in Spanish, they have their message in a literacy language that can reach our population. I think that we have to get involved, and we also have to demand that, you know, we're represented and that the communication is provided to our community.
And Devon, let me ask you, as a national leader in policy and advocacy, how can NHMA help you with this issue?
Yeah, so I really think what's really important or key to hearing from providers, when legislators, doctors, nurses, all these clinicians are really respected by our lawmakers. So when they hear these communities speak up and speak out of the problems that they're having, treating their patients and the problems they're having, ensuring that their patients are getting really the best care, you know, they listen. So I think really, you know, speaking to the problems, speaking to the solutions, and highlighting those examples of successes that the x-ray you showed is earlier, Dr. Rodriguez, is extremely powerful. And our policymakers are receptive to things, you know, simple, you know, ideas that are presented to them. For example, you know, like the slide showing the reduction, the shrinkage of the tumor from, you know, the targeted therapy. Things like that are extremely powerful. So really, you know, having our clinicians, our providers, you know, speak out is really goes, you know, a long way in knocking down some of these barriers.
Oh, great. Let me ask you for your last words here. We have 8 minutes left. First of all, let me see if there's any other question. Oh, well, this kind of goes along with what Devon, you just set this up. What type of information can clinicians provide for legislators to better understand the importance of biomarker testing? So you just told us one secret is showing up, having clinicians show up. And the second secret you told us was to have some visuals that can show very, very succinctly and very fast. We know policymakers have a very short attention span, and we need to show them something that's very powerful. What else do you think would be important if we were having a legislative day and a packet of information to the staff in the policymaker's office? What would resonate with them?
I would also say just making sure that what's presented to them is, you know, very quick and easy to understand. You know, us in the medical field, things can get really complicated with the jargon and all of these technical terms. So just breaking it down into, you know, quick and easy as best as you can. And sometimes it's difficult to do that, but just really taking a complicated idea and breaking it down as simply as you can to be able to quickly, you know, describe the problem, the solution, and then it's always helpful to back it up with that, you know, that patient's story or speaking to personal success of using a particular treatment or therapy for your patient.
Okay, great. And Dr. Rodriguez, just one question. You mentioned to me you were a leader of LMSA when you were in medical school in New York, and you're still a leader. We hope that all leaders, you know, I think it takes a long time for people to realize that whatever position you have the opportunity to lead and to be able to encourage others at your level, whether you're doctors or policymakers, to continue to carry the baton of leadership. What would you say to the young doctors and young medical students? How did you get to where you're at in terms of wanting to be a leader and keep your career?
Yeah, well, I think these days, middle career, everything that gets me frustrated is something I want to advocate for. So like prior authorizations, biomarker testing, you name it. Everything that I'm frustrated that contributes to physician burnout is an opportunity for you to use that energy in a positive way. But I have to say, you know, the finding your wolf pack, your group. And when I was very fortunate, I went to SUNY Downstate, and I just recently saw an article in JAMA about the attrition rate of minorities in medical school. And this is something that is still happening. And if the schools are prepared and have the support of national organizations that are providing mentorship for students, I was very fortunate that I participated in a pre-medical program that got me ready to enter medical school. I had a lot of mentoring and support when I was in medical school. I wasn't just thrown there. I had opportunities in leadership. So I think really find your group. There's people who want to help. I now see people that reach out to us through Twitter that are looking for advice. And I think just don't be shy, like you belong. And people are really want to help. I think people know where you've been. And now we want to see more people, more Hispanics get to medical school and succeed. So please reach out, don't be shy.
Yeah, well, thank you for that. And thank you for everything. So again, let me just close with the importance of okay, here's a slide. Here's our closing remarks here. Devon, did you want to say something? I'm sorry, Devon, I want both of you to have a closing remark.
Sure, I just will reiterate that, as presented today, biomarker testing and targeted therapies have the potential to make a huge impact on some cancer outcomes. There are notable barriers. One of them in particular is insurance coverage, and ACSCAN is really working hard to dismantle this barrier, and look forward to working with you if we can to really make sure that all patients who should get tested are. Okay.
Well, thank you very much, both of you. We have just a couple of announcements from the National Hispanic Medical Association to share with those of you who are still with us. We are having our national conference for the first time in many, many years outside of Washington, D.C. Next April 27th through the 30th, we're going to Chicago. I think what's important to know is that we are actively looking for new speakers and also for students who want to present their research posters or posters on their learning, service learning. And those are up on our website right now. The website is www.nhmamd.org. We're looking to hopefully develop the curriculum for this conference before Thanksgiving this year so that we can get more people to know about it, since we're going to go to Chicago. We're also very much involved with the CDC on our Vaccinate for All campaign, and we have websites with bilingual website, hispanichealth.info, with information on different diseases as well as vaccinations, and we have vaccinateforall.org. And we're very much interested in, like Dr. Rodriguez mentioned, having more individuals become champions with NHMA. We do have media training, media placement, and we're looking for Spanish-speaking doctors for our videos that we're doing for Instagram and social media. And we're helping our doctors become more visible. And that's the key, like you mentioned. And in terms of our upcoming events, we do have COVID-19 virtual briefings. They are quarterly now. The next one will be August 31st, 2022. Don't have the speakers yet. I think we're looking for them right now. And we also have a congressional briefing that we're going to do. Devon, you should know about this. This one's going to be about the respiratory diseases really coming from long COVID and COVID-19 and lessons learned about respiratory diseases. And we're going to showcase severe asthma, not just regular asthma, but severe asthma. And Congressman Raul Reese will be our opening speaker from the Congressional Hispanic Caucus. And that's not on here, but it is going to happen the last week of July. But again, look at our website, nhmamd.org, for that information. So with that, I want to thank Amgen again for supporting us, and the American Cancer Society for having you, Devon, as their leader. And Dr. Rodriguez, thank you very much for all your experience and knowledge. And I hope we can see you at our conference. We'd love to have you and others. Thank you very much.
Thank you.
Thanks,
thank you,
everyone.
and thank you, staff.
Thank you.
Okay, bye.